Thank you. As you join, could you add your name to the chat, your organisation and what you want to get from today's Lunch and Learn? I'd like to introduce myself as the chair of today's event. My name is Vicky Patel. I'm the chair of CAAW22, the National Quality Improvement Including Clinical Audit Network. I'm delighted to say that shortly we're also going to hear from James Mountford, the Director for National Improvement Strategy at NHS England and Improvement, and that's regarding the work in the Transformation Directorate, that is future-proofing health and care. We're also going to hear from the winner of our Future Proofing Clinical Audit Hero Award and about their experiences of effectively using clinical audit to make those improvements to health and care and how they've actually influenced that change. So just to introduce today's team then, I've obviously introduced myself. I've let you know that James is joining us as our key speaker, but we're also joined by Moj Ghonsani, who's our chair of the South East Clinical Effectiveness Network, and Moj's going to help us to facilitate today's session. So just to walk you briefly through the agenda then for the next hour and a half, we're going to briefly look at an introduction of CAAW22, and we're also going to look at why Clinical Audit Awareness Week is so important to our clinical audit community. We're going to touch on looking at future proofing and what that means from a clinical audit perspective, and then how we can start to think about effectively using clinical audit in this way. James is going to speak to us. He's also going to announce the winner of the Future Proofing Healthcare Audit Hero. They're going to present their project, which we're excited to hear about. And then we're going to move into a network opportunity with questions as well that's going to be framed around future proofing health and care. And then we'll aim to close by 2 p.m. Okay, so Clinical Audit Awareness Week then. So this is a collaborative event that's run in collaboration with HCRIP and CAAW22, and we run this on behalf of our local clinical audit community. So why are we all here doing what we do every day? It's about our shared purpose of ensuring high quality care for all. We're putting patients and service users first, and we're wanting to make a difference. We're helping patients and service users when they need it most. And ultimately, we're providing health and well-being to our local communities and all that are within that. So behind our purpose, we've got multi-factors, and they impact on every day and what we're doing, and we must be aware of these, and we've got to consider them in everything that we're doing. But ultimately, we're aiming to provide high quality care, effective care to all in the right place at the right time, whilst preventing harm, and we're providing that best ultimate experience. Now, to get that right, every minute of every day can be challenging, but we do try to strive to achieve this. We have that duty of care. It doesn't matter what type of health or social care organisation that you're associated with, we're ultimately all here for that same purpose. And that's about ensuring that we do get it right. And when we don't, we take time to reflect, learn and share together. It's about us identifying where we need to make improvements. We're measuring, we're implementing, we're evaluating, particular emphasis on equity and access, and we're sustaining those improvements. And this week has touched every day on these drivers behind our programmes of clinical audit for improvement. So this week provides us with an opportunity to share, network and celebrate what we achieve through clinical audit every day. And we want to learn and share together, and we want to do that on a far wider scale. We want to understand the challenges to effectively getting the most from clinical audit as a quality improvement process. And we want to take time to reflect, look at what's working and maybe where it's not quite right. Set ourselves some objectives to take away from this week, back to our own organisations, teams and patient service users. And it's about shining a light on the impact that clinical audit is making to improving patient care and services. And now we need to identify where our next destination is and how we're all going to get there together. So CAAW22 then. Our network is currently made up of 12 regional networks, and the attendees at the quarterly CAAW22 meetings consist of the 12 regional network chairs, 2 officers, which is the chair and the general secretary role, and non-officers and co-opted members. If you're not yet a member of your regional network, please do get in contact and we'll direct you to who your regional network chair is. Now, the chairs have all been involved in Clinical Audit Awareness Week this week. They've been interactive with everybody across each day. that we've been holding events. We're going to pop some contact details into the chat for you. We've also got the NNSF. This is a networking and sharing forum. And again, if you're not yet a registered member, head on over to the link and request to join. Becca's going to share the link and the nqi.cam1@nhs.net email in the chat. Fantastic platform to discuss, share and learn together how we're all using clinical audit for improvement. Now, NQI-CAN has a common purpose and it's got its forward plan. The regional networks are actively involved in this and they provide that voice into NQI-CAN from all types of health and social care organisations, and they take the voice back out to the networks from bodies such as NHS England and Improvement, HQIP, NICE, the Getting It Right First Time, Model Health System, Royal Colleges, and more. It's all about getting involved, making a difference and solving together. NQI-CAN does have annual priorities and we link these into task and finish groups to complete on these. All of this is cascaded through the regional network chairs to their members. So if you want to know more, head on over to the forum or get in contact directly with your regional network chair. And as I've said, the contact details will pop into the chat. You can either find it on the forum, on the NQI-CAN website, or you can email us directly. So we'd like to run a Mentimeter now with you, if that's okay, for 3 or 4 minutes. Becca's going to pop a link into the chat. So if you can click on that link and head over to the Mentimeter, we've got just one question for you. What would utilising clinical audit to future-proof healthcare look like to you? So if you click on the link, head on over. Becca's going to share the screen so that we can start to see some of your responses coming in and start rolling. We'll have a few minutes. You can submit as many responses as you want to. Lovely. So it's up on the screen now. Fantastic. Thank you. So let's get typing and posting and we'll see what's coming up. There's always a 20-30 second delay of things appearing. So what does utilising clinical audit to future-proof health and care look like to you? Have you all managed to access the link? If you just joined and you can't see the link, just scroll back up. If people are popping things in the chat, post link. Fantastic. First comments coming on. That means that we've had success. We've got people in. So yeah, improvements made through clinical audit, yet continuously monitored. Support that future planning of services. Yeah, fantastic. Yeah, data so that we know where to focus our QI projects on. Okay, we should be starting to see the screen rolling. Fantastic. Yeah, finding best practice to replicate across all services. Yeah, we want things to be consistent, don't we? Planning of services. Yeah, it's about feeding back in our audit findings, isn't it? So that we've got that further knowledge within our organisations to inform us how we should be making changes going forward. Yeah, undertaken to keep improvements in place. Yeah, we need to be seeing that effective, sustained change. It's a mechanism for improvement and sustainability. Fantastic. Education platforms. It's a brilliant learning tool. We must disseminate and share more widely. Yeah, we're ensuring what's being audited or measured is meaningful. If it's important to audit, it's important to do it well, isn't it? Aligning those data sets, yeah, we touched on triangulation on Wednesday when Sam Riley joined us for influencing change. We cannot undertake clinical audit in isolation. Yeah, linking patient safety, clinical audit teams, fantastic. Patient safety led and focused. Safe and good quality care for all. Brilliant. We've got something in the chat there about identifying funding gaps. Absolutely. Yeah, staff at all levels inputting. Engagement is absolutely critical from staff and patients and service users. all about getting those stakeholders right, isn't it? Yeah, we've seen that a few comments in here now. Any clinical audit will future-proof healthcare. Benchmarking, fantastic. Just doing a time check. Okay, let's give another minute. Yeah, mechanism for improvement and sustainability. Check if ideas are working. Yeah, that's brilliant. Okay, right, I'm going to take back screen sharing, Becca, if that's okay. So you should all now be seeing my slide. And I'll move you on. Fantastic. So I'm now just going to talk to you for 10 minutes really about clinical audit and future-proofing healthcare. So obviously our focus today is on how we can future-proof healthcare. It is important to acknowledge that absolutely this programme is so wide, and we're obviously going to try to think today about some of the points we're going to raise in terms of how we can apply that to clinical audit. So how do we define that future-proofing healthcare then? So it's all about building a health and care system that's ready for the future. This is a health and care system that's sustainable, it's equitable, it's accessible for all when we need it, in a way that we want to receive it, a way that we want to deliver it, and a way that we want to make it available. So we want it sustainable, equitable, safe, effective, and we want that positive patient or service user experience. Now, the health service must balance its responsibility to meet that immediate health and care need with the responsibility to actively promote health and prevent illness as well. So it must ensure that it's able to continue to provide high quality care into the future. Now, I know we just had a comment in the chat about commissioning, and it is sustainable commissioning, is about future-proofing healthcare as well. And this means ensuring that we're getting better outcomes for patients both now and in the future, despite increasing resource constraints. So equity, sustainability and efficiency have now been added into the domains of quality. So we must measure and drive sustainable improvements in care, embedding that sustainability into everyday practice. But to truly embrace sustainability into healthcare culture, we need to work towards including it in all of our education and training of all healthcare professionals. So the NHS long-term plan presents a vision of a revitalised culture of support and collaboration in the NHS, and that's underpinned by service improvement and transformation across systems and within providers. And this is echoed in the National Quality Board's shared commitment to quality, where they recognise sustainability as a domain of quality, and they also reinforce the need to focus on building workforce capability to improve that quality. So this is systems wide. It's not just focused on inpatient beds, but it's in health and care across the pathway, including prevention. And we need to find ways to integrate new innovations and care models, a new way of working, but enabling adoption at that faster pace. So, for example, we've got the newly mandated medical technologies through NICE and the Academic Health Sciences Networks. It's making technologies that have been proven to be more cost effective and give greater outcomes made available for use at a wider level. So naturally, as new innovations are adopted, we'll see more move to clinical audit and be included on our priority audit programmes. Now, the pandemic showed that we're resilient, but it also highlighted inequalities and more concern around life expectancy. But it also taught us that we can innovate at a faster pace. So we saw things like the hospital and GP appointments, they moved online, and records were shared and accessed at a faster pace. So it taught us that we need to ensure better outcomes for our patients both now and in the future. Now, if we reflect back on the topics of the learning lunches this week so far, on Monday we looked at patient safety and we talked about nobody should suffer harm as a direct result of receiving or not receiving health and care. Patient advocate, where no one should be redesigning or designing care and services without that direct engagement with those or those close to them that receive the care or use the service. Influencing change. We can't achieve change or adoption or innovation without engagement from everybody that's involved. And then health inequalities. We need to future-proof to ensure that we do address those health inequalities, and we don't want any changes that we make to negatively further or widen the gap rather than reduce it. If you introduce a piece of technology, it may reduce access for some patients because not everybody is techie. So you can see that the topics of the week, they've all been contributing to us starting to think today about future-proofing. So the biggest challenges then generally that we've got. So through all of the learning lunches this week, we've heard about where we need to improve across the whole system. We know that we've got an ageing population, an epidemic of long-term conditions, lifestyle risk factors in the young, and greater public expectations of health and care. Now, this is combined with rising costs and that constrained financial resources. And we also know that there's an increase in demand combined with rising costs that will threaten the financial stability and sustainability of the NHS. So we've now got to make our resources go probably further than ever before. We know we've got a diminished workforce who need the knowledge and skills to adapt and adopt. And there is a need to introduce technologies that will lead to efficiencies that then release that time to care. So it's about us being innovative, and it means thinking and doing differently. But to be more innovative, we need trust, safety, and freedom. We need to be more open to more progressive ways of doing, but we can't forget the patient experience and outcomes. As much as we want to go with the tried and tested, we may need to try and test, and we need that positive culture change, a shift of mindset, leaders and role models, actively involved in training and introduction of these new technologies. And we've got to do all of this and still maintain that high quality care for all. So we now need to be moving clinical audit along with this world of transformation. And I just want you to have a bit of reflection yourself in terms of have you got a transformation strategy in your own organisation? And if you have, where does clinical audit fit in with that? So it's not just about more resource, but how we can use our current resources more effectively, more wisely. How can we use the data to inform these decisions? And we saw some of these comments coming up just now in the Mentimeter. So we need to know where and what to future-proof. And this is about using what we already know and engaging those that can tell us if we don't know. We need to know how to future-proof. And this is thinking about influence and change. Where and how can we improve? Think about sustainability within future-proofing. We don't want to make a change in time. We want to make sustained change that really makes a difference. We need to think wider, bigger, and more collaboratively. And every single one of us is involved in health and care, and we've all got a role to play in getting us to where we need to be. So just wanted to touch briefly on the 4 stages of clinical audit. And if you think about stage 1, preparation and planning, we may need to think carefully about the topics that we're auditing, as we may now start to see an increase in auditing service redesign, role development, new patient pathways due to rapid change that's coming. Stage 2, around measuring performance, we may need to think about how we can measure high priority metrics and how we can get those embedded routinely into our systems and easily retrieved for review and action at any point in time, but plotted over time to understand that variation. And then if we're thinking about implementing change, we've got to think about whole systems, bigger scale, focus on prevention, self-management of health, think differently for the long term. Who do we need to link in with? And we need to start thinking about innovation. We've got teams that are working in innovation. And then stage 4, around sustaining improvement. What's been the impact of the changes that we've already implemented, and some of which have actually been quite fast paced in the last 2 years? So what's been the impact on care quality, and what's our vision going forward, and what does good look like? So we can't get through this week without sharing something from NHS Horizons. So it's the last night, literally, on the BMJ Leaders blog. Helen Bevan from NHS Horizons, alongside a gentleman called Goran Henriks. They've written a series of blogs, and it's all about creating tomorrow today. So it's worth going and having a read of this article. They talk about the actions that we can take as leaders that differs in varying contexts, but they're all about focusing on what unites us, welcoming diversity and difference and being inclusive. And they're looking at our role as leaders of transformation. So the first thing they're talking about is creating a climate of belonging. They're talking about leading in a way that creates feelings of belonging and to role model practices that create belonging. So the article focuses on how we acted and responded during COVID. So pre-COVID, they talk about us all being more obedient and diligent and utilised, and we were there with our expertise. During COVID, they saw us all reacting quickly. And what was seen was that people were having to use their initiative. They were creating solutions. They were working with courage outside of their comfort zones. And this was supported by leaders because we all have that shared purpose of getting through this. So what they're talking about is how do we actually retain some of that now post-pandemic? And they talk about high-performing teams or organisations that have got individuals that do work in this way. So they also touch on giving people resources and capabilities for improvement actually isn't enough. We also need the context and the opportunity to act. And this is within our teams, systems and organisations. So everyone needs to be involved in problem solving and decision making. And there's a big shift now from talking about empowering people, because they say that when we empower people, they're still operating with instructions that we set as leaders, and shifting it to what they're now talking about in terms of agency, building agency where individuals are actually in that self-leadership zone. So it's a really interesting article to go and read. So if you're on Twitter, they're asking you to join in that conversation and add hashtag creating tomorrow today. Now the image on the right is also shared by NHS Horizons. It's been created by Lee Kendall, and it talks about 10 ways to build agency for change. So I would urge you to go across and read that article. The other thing that I wanted to point out to you today was that if you've not heard of the School for Change through the NHS Horizons teams, please go and log on to the NHS website and have a look, because they've got some really, really good courses that are free to the NHS to join. And then finally, I just wanted to touch on what you can take away from today in terms of taking back to your own organisation. So on Wednesday in the Influencing Change Lunch and Learn, we heard from the Walsall team on fracture neck femur and how the audit department is separate from the QI team, but they innovatively involved all stakeholders and they linked in with many QI tools and methodologies into the clinical audit itself to achieve change that is sustaining. It's addressing the safety and the outcomes and the experience issues that were highlighted through their national clinical audit when they were an outlier. So I wanted to start to get you thinking about who you need to link in with in your organisation. You need to know your own organisation and where there are wider skills, knowledge and capabilities. What patient groups and engagement groups do you have where you can involve patient and service users? And think about your patient engagement hubs and Health Watch as well. What do you already know about in terms of gaps in your care, inequalities for your local community or wider if you're a tertiary centre? Would you know where to go to find out about this information locally in your own organisation? And finally, one last thing I wanted to touch on was the NACAPOT programme, the National Clinical Audit and Patient and Outcomes programme. For those of you that are in organisations that participate in any of these topics are driven by the long-term plan. They're telling us that these topics are important. They've been chosen because they are areas where we know that we need to future-proof. If you think back to the CAAW20+5 that Caroline shared yesterday, how do you respond locally when your national reports are published? Do you wait for that national report to be published to review, understand and take action? Or do you, where you can access your data earlier, really start to look early and triangulate, review with the right people at the right level and start to think about the true gaps and how we can now start to drive relevant and sustained improvements across the whole system that's in partnership with all the organisations in your area and the individuals that are involved to truly make it better for all. Our true gaps should be also then driving our local audit programmes, and we need to start thinking about taking our workforce along with us in what our priority audits should be, driven by a requirement to provide the right care for the right patient at the right time. So I'm now going to hand over to James, who's now going to talk with us about transformation to future-proof health and care.
Vicky, I'm sorry to interrupt you. Are you all right to take the slides down just for a second? And if I can ask you to look at the message on your phone. I've been liaising with Rebecca Campbell from NHS England. It's just to let you know that James has been delayed because of his train. So we're just requesting, Vicky, if we can just pause for a minute, everyone, if you can just bear with us. We're just going to slightly move the agenda round. So what we've negotiated is, Vicky, if you could take forward with announcing the winner.
Okay.
Work on the Mentimeter and take forward the network presentation. James is then going to be able to join us at 13:35, and he will then be would like to know about the winners and would like to give his presentation, and we've got a guarantee he will be there. I hope that's okay, and I'm sorry to interrupt.
You're fine. So I'm just going to confirm what you've just said then. So I'm going to move on and I'm going to talk about the
award winner.
Award winners.
Move forward with the Mentimeter. Do that. So I wanted your slides down so you can move to the right spot. There's nothing like it's iterative changes, isn't it, with quality improvement? We have to go with the flow. We love the ordering chaos, so bear with us just as we sort this out. So award winner, please, then Mentimeter, take forward the network session, and then we'll introduce James. Rebecca will let us know when he's here. Is that okay?
Right, so just bear with me because I'm just going to very, very quickly locate the
And just as Vicky's doing that, a message from Rebecca, apologies from James, so sorry not to be here as planned, but he's en route. It's not James's fault. There was a train cancellation. He will be with us and is very much looking to talking to everyone about future-proofing healthcare, and I am excited to be hearing him speaking as well. It builds on obviously what Vicky has just been talking to us, and my apologies for not being more involved in the discussion, but we were having a quick fire round of emails, etc.
No, you're fine, don't worry. Okay, right, just bear with me as I go back to sharing my screen then with you.
Yell if you want anything, Vicky, okay?
Okay, can you see my screen?
Yes, we can.
Fantastic. So before we move on to the winners of today, we just wanted to highlight retrospectively that on Wednesday for Influencing Change, we actually had a second highly commended audit hero that we wanted to announce to you. And this was the PIMS TS audit team at Sheffield Children's Hospital. So this was the paediatric multisystem syndrome temporarily associated with COVID-19. So we just wanted to formally announce that with you all. We're going to share some information on both the NQICAN website and the HCRIP website as well, so that you can find out some more information around that one for you. I'm going to move on to today's Future Proofing Awards then. And first of all, we just wanted to highly commend the Enhanced Care Support team at Bolton Hospital NHS Trust, who have done a lot of work around dementia. And this again was a worthy second place to our winner of today. They've taken forward a lot of innovative approaches to really start looking at how they can get dementia patients discharged quite proactively, so they're not in hospital for any prolonged period of time. And we've all, in all of our cities and towns, we're all supporting this patient group with dementia. So the issues that were highlighted within the project, we can all relate to within our own health and care organisations. It's a very worthy, highly commended audit heroes, and we just want to thank you for your submission and thank you for your good work. And we will be contacting you post session today so that we can look at how we can share this more widely. So that moves me on to announcing today's winners for Future Proofing Healthcare. And we're very excited to hear from this team very shortly. It is Newcastle, the Newcastle upon Tyne Hospitals NHS Foundation Trust. It's the Sustainable Respiratory Care Audit team that have won this award, respiratory, looking at asthma. And we were quite impressed with this in terms of taking some local recommendations forward and the innovative way that you have progressed with this project. So many, many congratulations. And I'm going to move on now and share your presentation. So is Alice there? Are you with us, Alice? And are you ready to start talking to your slides? Becca, could you just have a look in the attendance list to see if you can see Alice Fitzpatrick?
I can see her.
Alice is here. Yeah. Are you muted, Alice?
Doesn't look like she's muted. Maybe try quickly to leave and come back if Alice is having troubles with the sound.
Alice, we can't hear you at the moment.
Looks like she's just popped off and is hopefully going to pop back in.
Hopefully she'll be back on with us, because this, as I say, it was a really fantastic project. So I know the judges, shortlisters and judges, were really impressed with this one for future proofing and sustainability. So we're very excited to hear all about it. You let us know when you can see Alice joining again, Becca. You can all see the first slide, can't you? Sustainable respiratory care.
Yeah.
We can.
Fantastic. I'm not sure if Alice has got the rest of the team joining today, or whether she's here representing. Alice is a physician associate with a background in respiratory medicine, currently working in general practice.
Alice has just rejoined the meeting.
Fantastic. Can you hear us, and can we hear you, Alice?
Can see her.
Sarah Walpole from the team is here as well. I can see Sarah.
Fantastic. Sarah, can you hear, and can we hear you?
I don't know if Alice, it'd be better with your video off, perhaps. Anyway, thank you very much. We're very excited, and we've enjoyed preparing this presentation to sort of bring together where we're up to. I don't know if I should make a start while Alice is trying to connect.
Is that okay, Sarah? That'd be fantastic if you could.
Hopefully we won't overlap too much, and Alice can start to chip in as soon as she's available. Yeah, it's not letting Alice speak. Alternatively, I don't know if it would be better to do it a bit later on. I don't mind either way.
We probably need to start, if that's okay, Sarah. It's only because James Mountford, our key speaker, is slightly delayed with his train, so we've still got his presentation to move to. I've got the slide pack, so would you mind starting and letting me know when you want your slides to move forward? Would that be okay?
Okay, so I'll make a bit of a start, and then Alice can take over when she's available. So this is just to introduce you to our team, and we've got quite a multidisciplinary team. And we've really tried to make sure that we've involved respiratory nurses as well as respiratory physicians and general medics. And one of the interesting parts of our project has been taking this project from working in our local hospital in Newcastle, and then inviting teams from other hospitals around the country to join us and do the same audit so that we can compare results across different parts of the UK. So next slide. So the starting point for this really was we thought we wanted to do an audit based around a sustainability issue, so something that could reduce the carbon footprint of the health service in line with the NHS's commitment to reach net zero by 2040 and 2045 for its indirect emissions. And we know that inhalers are responsible for about 4% of the NHS's carbon footprint, so this would be a really good place to start. And you can see from this image that metered dose inhalers have a particularly high carbon footprint, and there is an alternative which is called a dry powdered inhaler, which many of you'll know. That's the type of inhaler that doesn't use a spacer and that crushes the drug and doesn't use a greenhouse gas to propel the giving of the dose of the drug. And for many patients, the DPI is actually much better suited to them and to their technique in terms of their inspiratory effort and coordinating the breath. So actually there could be a benefit for patients and for the environment for many patients to be on a different kind of inhaler, and for all patients making sure that they've got good technique will improve their control and reduce the risk of exacerbation and wastage of medication. Next slide.
That's me, isn't it?
So we also wanted to make sure we weren't just thinking about the medicine, that we were thinking about respiratory care holistically, so all the way from diagnosis to thinking about getting the right diagnosis and thinking about prevention, primary and secondary prevention, making sure patients have the inhaler that's best for them, making sure their technique is as good as we can get it, and importantly thinking about how you dispose of inhalers, because particularly MDIs put in the recycling or put in the household waste result in higher emissions of greenhouse gases than if you return them to the pharmacy and they can be disposed of appropriately. Next slide. So we started this project way back in 2020, just before things changed significantly, and we worked to develop a survey. We piloted it on different wards. We involved some medical students to help us to pilot it with different patients as well. We spoke to nurses on the ward and we learned quite a few things, like, for example, it's really important to check with the nurses on a patient's kind of cognition before we start doing the survey, and some things about how we worded the questions and making sure that the wording was written on the survey so that it was used in a sort of consistent way every time. And eventually we came to what we thought was a really good survey that we were then able to roll out in Newcastle. And as you can see, we had 20 patients that we discussed with over about 6 weeks. And we focused on discussing 4 different areas. So the type of prescription they're on, type of inhaler technique, what they knew about recycling, which we've mentioned is important, and whether they had a preference about whether their inhaler could be switched if that was appropriate for them. And I've just seen Alice is back, so I might hand over to Alice for the rest of the presentation.
Okay.
Hello, can you hear me now?
We can, Alice. Fantastic.
That drama, and I'm sorry, Sarah, you had to step in. So just to take over from what Sarah was saying in a quick introduction, my name's Alice and I'm a physician associate, and I was involved with the start of this project and then been tagging along since, helping with the data collection and things like that. So where Sarah was up to was our pilot study that we did in March 2020. And these are the main results that we're going to share today, because our current national project is still very much under analysis, and we've got a little bit of stuff to share at the end. So I did quite a lot of the data collection up on a respiratory ward, and I managed to get around about 20 patients, and I've got here the results that we shared from our DPIs. So these are the kind of the newer types of inhaler that we are looking to push for patients because they provide better technique, or what our audit shows that anyway, and they're better for the planet. So 16 of our patients had a DPI at the bedside, and the vast majority of them felt really very confident with how to use it, and they felt that they were getting the right treatment from their inhaler. When I asked them about inhaler recycling, the majority of them knew when their inhaler needed replacing. That's their blue Ventolin inhaler, but actually they only could tell me that by saying, it's just a feeling I get. I feel like it needs replacing. And then we went on to how they knew their DPIs were replaced, and that was really easy because it's got a dosage counter on, so they already knew that. And I think these results initially were exactly what we had expected them to say. Next slide. We checked the technique for their MDIs as well, so comparing the MDIs and the DPIs. And again, most of them felt very confident with their technique, and they all recalled, pretty much all recalled being shown how to use it before. So a healthcare professional had shown them how to use their inhaler and had checked it relatively recently. And an interesting part is in figure 4 here, and I know it's very small and we can send you a bigger version if you want to have a closer look. But it was about whether patients would mind switching their inhaler to something that provides them the same therapeutic benefit, but is better for the planet. And the vast majority of them said, if that's what you want, sounds fine with me. As long as they felt that they were getting the same treatment that was good for their chest, they were quite happy to switch to something else. And I've pulled out this quote that I got from one patient, and actually I think it's really, really representative of what a lot of people think about sustainability and about improving climate change. I suppose so. I'll change my inhaler, but will my one inhaler really make the difference? And the honest answer to that patient is probably no. Your single inhaler that's equivalent to me driving to Sheffield and back from Newcastle every day isn't really going to make that much of a difference. But if we put this on a big scale and we really make a push to change to those inhalers that are more sustainable but provide good therapeutic benefits, then we will see some changes. Next slide. So what did we do next? So we took the project national, and we used various different methods to recruit study teams throughout the UK. We've got a data team up in Scotland, and then the rest are within England. And currently we have 8 sites and around about 168 responses the last time that I looked at the data. And it's quite a big spread of regionally where we've got all the data from, and we did that via social media, the Centre for Sustainable Healthcare, local forums, and then contacting people that we knew who might be interested and seeing if they fancied joining in. Next slide, please. So the questionnaire, it is very much similar to the questionnaire that we used up in Newcastle originally, but what we did this time was we did 2 webinars where we invited all interested parties, which included a range of clinicians, those who were interested in respiratory and sustainability, those who were already working in the area, and from a range of clinical backgrounds. We took feedback on the original questionnaire and put in a lot of changes to expand from around about 8 questions up to a 17-question questionnaire. That includes their inhalers. We wanted them to show us their technique. We asked them questions about replacement, recycling, and then finally their preferences. And then just to make sure we had all the information that we would need, we asked for their respiratory diagnosis and checked capacity to take part in the project. Ready for the next one? So the results are still coming in, and this is all we've got so far because we're still very much in the process of it. But what you can see on the left is that respiratory diagnosis. The vast majority of the patients that we've surveyed have either a single diagnosis of asthma or COPD, which is pretty much what we were aiming for as the main people who will be using these types of inhalers. And then we've got data from the patients that we have so far on their DPI confidence technique. And unfortunately, there's quite a lot missing, which is a bit frustrating. But what we do have is that most of them feel confident, and that's a good sign. Next slide, please. We also have that data of, do you know how to dispose of your inhalers? And if so, how? This is a question that we've expanded quite significantly since the start. We've characterised, is it a household bin? Do you put it in your recycling bin, or do you take it back to your pharmacy? And unsurprisingly, the vast majority of patients chuck it in the bin, which, you know, fair enough to presume that that's how you would dispose of your inhaler, when actually it is possible to recycle some parts of the inhaler if you take it back to a pharmacy. So we can see here already that we've got an opportunity to do some patient education in various different fields to kind of improve how they're disposing of their inhalers and take that bit out of the mix as well. Next. So conclusions, we're not able to say yet because we're still knee deep in data, but a scan of the results suggests that the results are going to be pretty similar and the conclusions are going to be in line with the pilot audit. So the overall DPI technique is better than MDI technique. So that's the newer inhalers versus your classic blue Ventolin inhaler. They're better with the newer inhalers. The knowledge of inhaler recycling is pretty poor, and that's an opportunity for us to step in and do some patient education. Most patients would switch an inhaler to reduce carbon emissions, as long as it gives the same therapeutic benefit, and that's what's really important to the patients. So a bit of a kind of a loose conclusion, but I think that's what I can draw from it, is that if we switch to DPIs, we might be able to improve patient treatment because their technique is better, so they're getting more therapy. And we can help reduce the NHS's carbon footprint by using an inhaler that's more sustainable. Once we get the big results, we'll be happy to share them.
Thank you so much. It was a good double act.
Great stuff.
What I'm going to do now is I'm just going to take down those slides and just see if we've got any questions for the team. Let's have a look and see if anybody's got their hands up.
There's a question in the chat about whether pharmacies do recycle inhalers. Unfortunately, there are very few recycling schemes. Some of the companies that produce inhalers, 2 of them have set up schemes, but that's very limited coverage, unfortunately. So the majority of times pharmacies actually give the inhalers for incineration, but that's still better than this greenhouse gas that's within the canisters just being released into the environment through household waste or recycling. So it's still important they go back to pharmacies, and I think the more that go back to pharmacies, the more likely it is that the pressure can be put on to make sure that appropriate disposal does start to happen.
Brilliant, that's really good. Moj again?
Yes, good afternoon, thank you, and thank you very much for the presentation. Found it really helpful. I just wondered what the engagement has been with the broader area prescribing committee in terms of formulary management and I suppose the expansion of your project across the area and the system. Thank you.
Shall I mention what's happening in Newcastle hospitals? Because Alice is currently working in general practice and things are different between primary and secondary care. So one of the things that's been happening is there's been some attempts to try and link up prescribing between primary and secondary care, because obviously it's all very well for one side of the coin to say, let's put you on this inhaler that'll be better for you. But if they go back to the other place and get prescribed the other inhaler, it just becomes confusing and not beneficial. So there is some work to link those up. In Newcastle, there's been some work going on recently to revise the formulary, and this time, as has not happened before, the kind of environmental impacts have been taken into account. So it's putting DPIs first as first choice for patients that works for, and then obviously having an MDI option available in case a patient needs that as well. And the other thing that we've done, which we didn't have time to tell you about, is we've created a poster to inform prescribers and clinicians about which inhalers are which, because it's a very confusing landscape now with so many different types of inhaler. We're very happy to share that poster. It took a long time to make it work out what was what and get all the details down. So we're very happy to share that. And that just helps prescribers to know which are MDIs, which are DPIs, and importantly reminds them to give a spacer and ensure that patients know how to use it if patients are on an MDI.
And in primary care, it is changing. We had just a talk yesterday on a very similar project that they've done here in South Tyneside, and they are now moving to starting off patients on DPIs, because some of the problem has been that once they've tried an MDI, they like the sensation that they get from it because it feels like that puff rather than actually the treatment, and they're used to that. So there's work in primary care at the moment with various CCGs in our region to stop people ever trying an MDI so that they never get that feeling, but they still get the great therapeutic benefit from a DPI, and then they don't feel, oh, I need to rely on that blue inhaler. I suppose a bit of a problem might be is that in primary care, for spirometry, when you're making a diagnosis of respiratory disease, that they use an MDI. So that was highlighted yesterday as something that we need to work on. Is there a way for us to change that so that we're not introducing that into their care at all, and just sticking with the DPI. So it is coming in primary care as well.
That's really good. So it's across the pathway, isn't it? It's fantastic. That's really good. Conscious of time as well. So has James joined us at all?
So James due to join us at 13:35. So there was the request about the Mentimeter, but there was also the request about the networking session being done beforehand. I just wonder, Vicky, will the Mentimeter allow us to explore some more questions? If not, there were a couple of points made in the chat, and I've got a question. Well, a question, I suppose, a point, taking us back to the clinical audit perspective. So happy to raise that point if you would like me to.
Do you want to raise that point first, and then
okay,
do we want to go to the Mentimeter, James's Mentimeter?
Yes, that will be the one.
Yeah, that's fine then. So do you want to raise your query first, Sarah?
Yeah, and my apologies. I hope I'm interpreting this in the right way, but on slide 11, you were talking about, does your clinical audit program consist of clinical audits that focus on measurement of new technologies and ways of working? And as those of you that will know me, I'm Sarah Chesel. I'm the lead for the Dorset Innovation Hub and General Secretary, Deputy Chair for NQI CAN. So working very closely with Vicky and the regional chairs and with HQIP. My role in innovation, I used to head up research, innovation, NICE and clinical audit, but my role is no different. We use clinical audit as part of innovation, and that question, that point you've raised really resonates for me. So in our old clinical audit programme at Poole Hospital, as it was then, I now work at University Hospital Dorset, we merged organisations. We would have a NICE programme, and on our clinical audit programme, we would look at auditing NICE guidance. Now, when we look at NICE guidance, we've obviously got the evidence base in place. We're looking at new technologies, new ways of working, and NICE give us that fantastic springboard where we can actually just look at getting new technologies and ways of working into progress. So I suppose I would like to just do a straw poll. If people can raise their hand electronically, do you include clinical audits in your programme that look at the med tech funding mandate? So you might have seen me tweeting on heart flow, which is a non-invasive cardiology piece of NICE guidance. There's Securicast, we've got the urology pieces. Does anybody know about whether they use the medtech? So medtech funding mandate, it is about getting the NICE guidance into practice. We've got no hands raised that I can see.
Can't see any.
What I would actually say is, do please, as a take home, I will add it as a link to the chat in a minute, but do as a take home, please just go back to your organisations and have a look. NICE may be separate from your audit programme, I recognise that, but just have a look at, are you undertaking any audits of NICE guidance? So Securicast is a way of having a central venous access device. That's mainly for oncology and critical care. That reduces impact to patients. Gamma Core is about cluster migraines. It's about reducing that debilitating cluster migraines in the community. Placental growth factor is another one, and that's about reducing the impact to mum and baby. So it's about identifying preeclampsia early and reducing mortality. And then heart flow. So it's about a non-invasive procedure that actually really does improve patient outcomes. I'll put a link in the chat. I don't want to hog the time, Vicky, but please do just look back at your organisations and just find out, are you implementing that NICE guidance where it's applicable to your trusts? And actually, what are your standards of care against that? And actually, more than happy, I'll put my email in the chat, more than happy to talk to anyone further about that if they'd like to. I hope that's helpful, Vicky.
No, that's brilliant. And we've obviously, your organisation will be working really, really closely with your academic health science network, and they are starting to engage with our regional networks, and then we're also planning for them to come to the NQI CAN meeting later on this year. So there'll be a lot more information cascaded down. I met with them literally last week, and they talked about the fact that they want to start working with all of our organisations to make sure that we're auditing. So it is coming. So you're quite right to bring it up, Sarah. So I'd go and have a chat with whoever is responsible for implementing NICE guidance within your own organisation, because they know about these pieces. So yeah, thank you, Sarah. Now then, Becca, shall we move to the 2 questions that we've set up in the Mentimeter for James, please? So if in the chat, we're going to put some links again, or a link to the next Mentimeter. And James has posted 2 questions to us, of which you'll see coming up onto the Mentimeter. Becca will share the screen again for a roll in. So the first one is around what current strengths should we build on nationally in terms of best link audits to improve results for patients, populations and staff. So what current strengths should we build on nationally and how? And then what should the national tier change in terms of what it does and how? Does everybody understand that? So to best link our audits to improved results for patients, populations and staff, 2 elements. What current strengths should we then build on nationally, and how should we be building on that nationally? And what should the national tier change in terms of what it does and how?
I think folk will just be thinking about their answer, Vicky. It's quite
Yeah,
a broad question, isn't it?
Yeah, totally. Totally.
I don't think people can move on to the second question until I move the presentation onto it.
So I think it's, first of all, what are the current strengths that we should build on further? This is from the national perspective that's going to help us all locally. And this is all about improving things for the patients, our local populations, our staff, our teams. Here we go. Ensuring sustainability considerations as well as patient benefit and cost. Yeah. This is building our healthcare for the future. So I'm assuming because we put it down for this question that we feel that actually that's something that is currently a strength, but we need to build on that further nationally. Yeah, effective communication connections, better use of social media. Yeah, we've got quite a growing following on social media now, haven't we? And it's such a fast way to get comms out and comms back in. And we've seen some amazing Twitter chats and conversations going on more recently, haven't we? That's been led nationally, which is fantastic. And we've seen some local ones going on as well. Yeah, effectiveness of the audit process, focus on tech. Yeah, too many paper forms and charts, scanning, typing. How can we move audit forward with that technology? Capacity is limited in audit teams now. Yeah, capacity limited in audit teams now, so some changes are needed to support change at board level. Yeah, to understand the changes needed. This, yeah, what comms could we be sending out nationally then to local boards in terms of how we need to be changing and moving forward? We've talked a lot this week about having boards behind us supporting and investing and providing that clear direction and leadership for us to then take that change forward. Yeah, timely reporting of data, absolutely, as we're seeing the national clinical audit and benchmarking data moving into the model health system. We've obviously been assured of more frequent data and more timely, shorter reporting as well. So we should naturally start to see more timely reporting of that data. Okay. Timely reporting of data again. Yeah, again, we've got some comments about the national audit data being old. Obviously, I think we're going to start to see things changing there. That has been taken on board. So if you're not yet registered with the model health system, please get registered, because by the end of this year, the NACPOP audits will all be in the model health system.
I suppose, Vicky, if I may, it's about turning it on its head. James is asking here, what are the current strengths? What can we build on nationally? So the National Audit Programme, recognising that there are always areas for improvement. The national programme is the absolute gem when we look at quality and measurement. Sometimes, you know, the delays in data about outcome data being provided, and that takes time. So it is in the context of the type of audit as well. I hope you don't mind me suggesting that.
No, not at all. I think what we're seeing here are some responses for both questions coming through.
Yeah. I
think we may have to have a look and tease some of these out in terms of the ones where they're saying that we do well, but we could build upon further, and then some of the things that we're obviously acknowledging that we need to improve on. Some of the challenges are in here, I feel, but they're not challenges we don't know about. And you're right, they're being addressed, they're being discussed. We're trying to find ways forward with these things, aren't we? There are a number of national audits now where data is there and we can download it into dashboards, SPC charts, etc. So I think where we know we can access that data, we should be doing so promptly, timely, so that we're taking that local action upon it. A national report gets published, we're benchmarking, aren't we? But we already know our local data, fitting in with our local community and where we need to make improvements. Yeah, willingness to follow up on the results and actions. So again, we can have guidance from the national audits, can't we, in terms of how to take things forward locally, but we need that local buy-in to really make that change on the ground with our local communities, don't we?
Vicky, I think James is here.
Oh, fantastic.
I think I can see James.
I am.
You're here, James.
Vicky, don't let me break your stride. Carry on, please.
So we've gone to your 2 questions, and then obviously I'll get us back to your first slide, James. So we've just got the Mentimeter going, but we feel from some of the responses that we may have answers to both questions here in this first one, because we've got some good things coming through, and we've also got some things where people are highlighting that maybe we could start to look at some improvements. So quite a lot of information here. Quite a lot of information. So the Mentimeters that we've been doing throughout the whole week, we will be collating and we will be making them then the information available to you publicly. So just bear with us, because there is a lot of information that's come through this week. Fantastic. Will these Mentimeters stay open, Becca, whilst we're on the call?
I've been closing them so I could download the results, but I can leave it open.
Well, there's quite a bit here. I'm just thinking what I'm going to do now then is I'm going to move to getting your first slide up then, James. So just bear with me as I head back, because I'm obviously having to go backwards and forwards in the slide pack. So just let me get you to your first slide. And I think in the interest of time, because we've just gone past 1:30, we'll move to your presentation, James. And then we've still got the opportunity for some questions and some further networking following your slides. So I'm hoping that you can now see.
I can. That sounds terrific. And I'm most grateful, Vicky, for the flexibility. It proves that you don't actually need a full train strike to create problems. So good afternoon, everybody. My name's James Mountford from the Improvement Directorate in NHS England and Improvement, and it's a real pleasure to be here, and an honour really, because you've had so many things happening during the week, and that vibrant set of ideas that was just on the screen to come into is just fantastic to hear. And I don't know exactly how many people are in the room. But I think it's over 100. And the sun, I'm in central London, the sun is burning down outside. It's a Friday afternoon. And so that speaks quite a lot about the potential that people see in this. And I don't mean in my talk, I mean in the topic of bringing audit ever more practical, ever more to feel a sense that it's giving something useful and insightful to the people who are doing the work to help us get better. And that's really the focus of my talk. And what I want to do is try to talk for no more than, say, 10 to 15 minutes maximum, and then have a discussion however best we can, either through the chat box or through people speaking in. So if you've got a question or an idea as we go along, please just pop it into the chat. So if you would go to the first slide. So I came to NHS England from the Royal Free, and my boss there was Stephen Powis, who was the medical director at the Royal Free before National Medical Director role. And here's what he said 7 years ago in a review of audit that the Academy of Royal Medical Colleges did. Now, obviously, medicine is but one voice among many, but I thought it was quite striking to really be this bold around the skills of improvement. And I think there's too much where perhaps, although I think we're getting better, but there's too much where we talk about audit or improvement, when in fact, audit is a very, very important part of improvement, would be one key message I want to put today. So if you go to the next slide, this just illustrates it. And I can talk about this in rather glowing terms because I had absolutely nothing to do with it. It's not even from England, it's from Scotland, from a busy intensive care unit, and it's a very busy slide. So it'll take me a moment, if you'll allow me, just to explain what you're seeing. So you've got several years along the horizontal axis in months. Each of those bars is 1 month. And then you've got the compliance, the concordance with the so-called ventilator-acquired pneumonia bundle, scored all or nothing. So if you did all the elements of the bundle, then you got a yes. If you didn't, you got a no. And the percentage compliance over the month is shown in those blue dots. Now, the height of the bars shows you the number of cases of ventilator-acquired pneumonia that the unit had. Ventilator-acquired pneumonia, there'll be people in the room who know, people who don't, essentially think of it as a very nasty at best, potentially fatal, always very costly complication of being paralyzed and ventilated, having a tube to breathe through. And it used to be believed, a bit like, you know, a human being couldn't run a mile in under 4 minutes, and people were trying and trying for years and they couldn't. And then Roger Bannister, a neurologist trainee in Oxford, put on his shoes one day after training and got under 4 minutes at the track in Oxford. And that was remarkable. But I think more interesting for our purposes is that in the year after that, remember, lots of people have been trying for lots of time, nearly a dozen people met that mark as well. And so with ventilator-acquired pneumonia, we have thought until these data, they're several years old, that if you have patients tubed and ventilated, it's a necessary cost. You're always going to have VAP with us. But then New England Journal, I think an Australian journal, published around the same time saying you can eliminate it. So how do we get that knowledge to every bedside to benefit every patient? Well, you use an improvement method, central to which is measurement, but also the serial doing and testing of your changes to see what works. And that's what happened in this unit. It doesn't matter what the changes are, but they're annotated on the chart. And the really crucial thing is the measurement linking inputs that matter, whose reliability matters, to outcomes that we care about and the time series nature of that. And I just want to finish on this slide by those 2 dots. I don't think my cursor showed. Do you see those 2 isolated blue dots on the left? So those don't look like they're associated with any improvement. Of course, all of the improvement is correlation. It's not causative, but I'd rather have my mother or father in this unit from a VAP perspective in the 2 years on the right than on the left. And those 2 dots are counting without linking to tests of changes and review. So the sort of classic misunderstanding of audit as just counting and then counting again is what you saw there. You've got the counting, you've not got any improvement, but then when you start counting linked to planned tests and review, you can eliminate this lethal complication. So you go to the next. It's just another example of this. I'll be briefer on this. It's from the Royal Free again, looking at staff. So we don't know what an ideal staff turnover of qualified nurses is, but we can be pretty sure it's not 40%, which is where the 2 units in Barnet and in Hampstead, whose data this is, started out. And again, they did the same thing. They kept auditing the turnover and they linked it to a big exercise. And when I looked at the winner, congratulations to you in Newcastle, congratulations to Sheffield as runner-up. You know, you've done all of that. You've done the determining of what you need to do. You've thought about the changes that you need to do. You've mobilized multiple communities. But what I didn't see there was any time series measurement. And that's the missing piece, I think, perhaps that's the missing piece where we can actually demonstrate whether we're getting better. And that is a real tonic for staff, any of us in the room who've seen that. I mean, think about, you know, outside of work, if we're trying to hit a step count or, you know, to hit a weight goal or something, it's the data combined with what you need to do to get there that's the tonic. So if you move on, there's 4 deceptively simple questions coming up. We'll happy to circulate these slides, but you know, if anyone wants to take a photo of this one, I really would be pleased, because I think these should be at our hand as we approach our work. And I call them deceptively simple because they look simple, but they require a lot of thought and consideration, and they require a consideration of how we will define good. So we might be running an ED department. Well, it's not just the government's target on access that defines how good we are. We know that. So it's what are the outcomes and patient experience? What is the level of equity across our population? What is the efficiency, the use of the public's money? And what's the staff well-being and satisfaction that underpins those 4 points of what we call the quadruple aim. And what specifically are the things that you need to measure to define how good you are? We're a much more complex world than a business. So a business is got sales, it's got costs, and ultimately, if it's a for-profit business, what counts is the return on capital. That's true if you're making Wellingtons or TVs or software, doesn't matter. We cannot boil our purpose, our function, how we describe what we're trying to do to one metric. We've got to think about the work that we do in the context of those 4 dimensions: outcomes and experience for patients, the well-being of staff underpinning everything, the population health and equity, and the use of resources. So what good is depends on what you're doing, of course. Second question, the peer comparisons, the same. If you're an ED department, well, it's probably the other ED departments in your town or region. But if you're, again, from the Royal Free, the lysosomal storage disease unit or the amyloid unit, there's only one of those in the country. So your peer comparator is going to have to be abroad. The variation. So again, we could take whole days on this, but where is your variation? What is its origin? Is it night versus day? Is it Ward A versus Ward B? Is it Team A versus Team B? What is it? And crucially, think to that time series. Do we know our rate of improvement over time? Are we actually getting better? So on the next slide, I just want to, and I'm going to start transitioning now to some hooks that I hope are going to be helpful concepts and tools for you to turn your will to get better and your measurements into actual tangible evidence that you're getting better. So this is work from UCL Partners. It started in the pandemic and it's continued through recovery. And they've applied this to things like vaccination, to elective access, to emergency care as well. And it's really saying that there's lots of things that we don't know. And the fact that they're published in the literature or they're specified in national guidance is not necessarily very helpful, because it tells you maybe what to do, but it doesn't tell you how in the environment that you have. So if you're thinking about how do we get the vaccination rate up among our population, well, think about the data that you need to do that and how you might cut it. And it happens in this case that when they cut the data by ethnicity, it showed that people who identified as white and who were older were more likely to be vaccinated. Fine, we know that. When you then blow up the data of white, it turns out that some communities, Lithuanians and Latvians, as it happens, in North London, are lower in their vaccination uptake than most of the BAME communities. So you wouldn't see that if you didn't disaggregate the data and if you didn't have a curiosity about how you could get your vaccination rate up for everybody. So then that immediately, if you just think about the rest of this loop, starts to offer you ideas that you can generate and test. Some of them kind of obvious, almost must-dos, you know, produce leaflets in Lithuanian and Latvian, find out where they congregate, go to the community center, go to the churches where they go, find peer workers. But then there's other things that you do need to test into action and discover what works. On the next slide, again, in its early days, some work that we're doing nationally, several people on the call, and I thank the team around it. Sorry that the font has gone a little bit off here. But really, for the purposes of here, the detail isn't important. The point is that there's a national piece of work that's starting to work out how can we create conditions through national policy which legitimize and focus on learning and set up a series of resources to help you do that. So talking of resources, a good network helps. And on the next slide, the Beneficial Changes Network is entering in the autumn its 3rd year. And this, again, a bit like the UCLP learning work, it started in COVID, but it can play forward into normal diseases and normal times. The fonts are too small there, but as I say, we will circulate the slides, but there's all sorts of resources, communities, tools, networking sessions, that on the Futures platform, a whole set of things that you can drill down into. If you go on to the next page, these 3 pillars of the good network: published evidence, evaluated rigorously, learning from others. So we want people to contribute their knowledge as well as draw down on it. And as Helen Uthwaite, the knowledge lead for our team, said on the stage at Confed yesterday, If you're struggling to negotiate this, and if the Futures platform is unfriendly, by the way, it's being revamped and getting better, come and talk to us. So you've got in Helen and team personal shoppers who can guide you around the knowledge landscape. And absolutely, as a golden thread running through all of this has been to work with patients, service users and families in a spirit of really true co-production with equal power in terms of where this focuses and what those changes are. On the next page, and we're really in the home straight here, some capability programs. Again, the font's too big, but what this basically says is there's the basic improvement toolkit, CUSA. Many people in the room, I'm sure, have taken that either singly or in your teams. Latterly, CUSA has gone virtual and also become much more team-based around applied learning. So to a problem, back where we started, what are you trying to achieve and are you getting better over time? And then people may have heard of MOOCs, massive open online courses in the blue at the bottom. These are enrolling and rolling now, and we can send details, but they're open to all, free of charge to people who are part of the NHS. So then just to conclude, we've been at improvement, if you go to the next slide, for probably 2 decades now from original seeds. I think we started off with some awareness, 2 decades ago, is quality measurable was a legitimate question. We know there's lots of fallacies of the measurement of quality, lots of pitfalls, but no one really seriously disputes now that quality is measurable. We've invested and other bodies outside of the NHS, like the Health Foundation and other charities. There'll be Health Foundation fellows in the room. The CAAW Fellowship has 4,000 members across the 5 UK and Ireland nations. So there are lots of examples. There'll be probably somewhere in all of your institutions, wherever you are, which has applied improvement to make things better. But very few institutions have done that as a core part of the management system. Some have. I won't name check it here because it would be unfair to single out, but there's mental health institutions, there's acute trusts, there's GP practices for whom really the thread of quality and the management of quality around that quadruple aim does describe their management system. But that's not the norm. And if we're honest, that's not the practices and the management systems that one would expect to emerge from the policy of NHS England. So we are reviewing improvement, the delivery and continuous improvement review chartered by Amanda Pritchard as Chief Exec and Sir David Sloman as Chief Operating Officer, being led by Anne Eden and Catherine Pereira. Anne Eden, the Regional Director for the South East, and Catherine Pereira with us, a colleague in NHS England, Director of the Horizons team. A really big exercise looking internationally, looking locally, historically, and now at examples of what's working. And it's as you can see, you can read the purpose of the review on there: co-production, evidence-based, try and eliminate this odd duality between operations, doing things, and improvement, learning and getting better. Great organizations, learning organizations blend the two. They learn from every patient and they make the standard work better as a result. So on the last slide that we have, we would love you to pitch in, scan the QR code and sign up for this event in a month's time, an accelerated design event. Honestly, we cannot sit in Wellington House now, it was Skipton House in London, and design this. It needs to be done by the people who are doing the work closest to the patients and closest to their colleagues. So if you're free, Friday, the 12th of July, it'll probably be another sunny Friday lunchtime like this. Please, please, please sign up and come to that. And that really is all I wanted to say. On the next slide, I think you've already done that exercise. So Vicky, I will stop there, and whatever other time we have, I'd love to have a dialogue with people. Thank you very much for inviting us along, and congratulations again to the winners, but really to everybody who's taken part in this week and who makes audit part of their routine to get better every day. Thank you.
Lovely. Thank you, James. That was absolutely fantastic. I can already see a question straight at us in the chat here from Hilary that says this is all looking really good, but the problem is that there are just so many networks that it's really difficult to keep up with them all. There are just so many resources that we can look at, but most of us have a day job to do as well. How does all this fit in with Chain and SHA and all the other ones which regularly share great resources?
So, Hilary, I think that's an excellent question. And I don't want anyone to feel forced to play in any network that I'm involved in. What I want the network to do is, in fact, to sort of hit a basic assumption that's in your question. So the network, other than being, kind of fun and developmental perhaps, but in terms of the work, the network is only as good as it helps everyone do their core day job work better, faster, easier, with more joy. So I would encourage you to think about where you can find networks, wherever they are, that help you do that. And don't play with networks that don't help you do that. They are a waste of your time.
Fantastic, thank you. Mojgan, shall I hand over to yourself to facilitate some questions and discussion?
Yes, thank you very much. Good afternoon, everyone. I'm Mojgan. I'm the chair for the Southeast Network Group. Any other questions from James, or would you like me to move to our networking questions?
Mojam, we did have one actually in the chat very, very early on that I think is a really good one that we perhaps ought to explore. So at 12:34, Sally Bray actually said she wanted to learn more about protecting her services and the team. Sally, I don't know if you're still on, but that feels a really real question that many folk with all the different changes are thinking about. Is Sally still here? She may have dipped off now. But James, I don't know if you've got any advice, any thoughts for Sally and her team.
So unfortunately, my chat starts at about 1:29. So could you just give me the question again?
Well, it was a point we asked folk what they'd like to get from the session, and Sally wanted to understand, learn more about protecting her services and her team. So she's within a team.
I mean, I don't know, Sally, if you're on the line, I'm keen to understand what you mean by that word protect. That's pretty crucial to being able to respond to your question.
I don't think she's
are you there,
here
Sally?
Now.
I mean, well, look, let me then interpret it as best I can. So I'm going to answer it in a slightly oblique way, perhaps, but to say that some of the best work in terms of generating results for patients and greater efficiency has come from work which has been designed with the aim, so that the headline, what are we here to do? The aim of somehow improving the lot of staff. And I think it is incontrovertible that we will not get, no health system, no enterprise gets great results for its mission if it's not looking after its people and it's not letting its people feel that they can express themselves, that they can discover better, that they are, I mean, I'll just use the term that their work is bringing them some joy. So that's the classic term from Deming, joy in work. He doesn't mean joy at work, right? As in, parties and stuff. He means that the way you go about your work is showing you how you are valued, how you are making a contribution through your ideas and the way that they're tested by the management system and the way you're led to being fulfilled. Because, and this was, essentially writing about manufacturing, car components and all other sorts of stuff. So again, I'll go back to examples that I did at the Royal Free, stuff that had been stuck, that cost improvement teams, quips, transformation efforts had got nowhere on, when the same people, it's always the same people, were given an improvement coach and taught a little bit of improvement at the sort of shoulder of a project to make their lot better. So, you know, stuff like how can we get 80% of us to go home on an average day having had a good day rather than the 20%, 40% baseline that we've got. So that can lead to happier staff, but it can also lead to better patient flow, you know, in a radiology department, reduced waits, reduced scans, reconfiguring care so that patients don't have to come twice, all of that sort of stuff. So, I mean, I honestly believe, I'm not saying this, Sally, for your question, I honestly believe that our route to efficiency, quality and safety is through our staff, because guess what? People don't work in the NHS by and large if they don't want to do a great job for their patients and their colleagues, right? So the management system needs to unlock that. So, you know, that's the best answer I can give to your question without any more context around protect. I do want to just highlight, there's a question from Lorraine. No, hang on, it's not Lorraine. Somebody was saying about poor relations. Sorry, it's Zoe. Do you think clinical audit, Zoe, can I come to your question? Do you think clinical audit is becoming a poor relation to QI method of improvement? And how would you respond to QI staff who don't recognize CA as QI? So I would absolutely go with your instincts clearly, Zoe, and I hope what you're doing in Barnsley is to say this is a false choice. It's a completely false choice. It's a bit like saying, you know, is are the forwards or the goalkeeper or the midfield more important in a football team? Is, you know, or the batsman or the bowlers? Completely ridiculous. What I would say is that if all you do is measure, you know, the sort of it's a Palestinian proverb apparently that you can't fatten a cow just by weighing it, right? So if all you do is measure and then measure again, you're unlikely to get better. But good audit, as you say here, is laying the foundations for how those tests of change are done. So audit is integral to improvement, would be my answer. And I think places where, you know, there's the stock price of the audit team is seen to go down if the stock price of the improvement team goes up, you know, that is not where we want to be.
Thank you. Any other questions?
I think we're virtually about to close, aren't we? But I think Jenna's popped one in from Rotherham, Doncaster and South Humber around. They're running a service, they're running a group for staff called Thinking Space, where staff can reflect, explore cases, vent, and it was viewed by staff as helpful when they explored that in their research project. Yeah, some recommendations highlighted, so we're now looking to make these monitoring. That's really good.
So if I could just come in there, so, you know, what would be really unhelpful would be to then come along with an efficiency drive and go, oh, you know, where's the benefit of this? And your defense against that, I think, will be, I'll come back perhaps to close, Jenna, with reference to this diamond of the quadruple aim, right? So how does that impact your staff satisfaction and your staff well-being, your sickness, your absence, your turnover, willingness to recommend, and how does it appear to dovetail and correlate with changes to those other three dimensions, including outcomes for patients? It can all move in the same direction. I promise you, we all know that in ourselves, right? We all know that the most efficient care is the most patient-centered and the most joyful to be giving. So do not believe people who tell you that this is a false choice.
Thank you, James. That's fantastic. We're on 2 o'clock, so we're going to have to bring this to a close, I'm afraid. It's been a really, really good session, and thanks, James, for attending and speaking with us, and your whole team that are here with you that have been supporting as well. And obviously to our winner and our highly commended. It was fantastic to hear from your project. Becca's popped a link to an evaluation form in the chat. Please, please, please do click on it and fill it in, because we use your feedback to plan future events. It's really, really valuable. This is the last Learn and Lunch for the week, for Clinical Audit Awareness Week. We want you to think about everything that you've learned from the week and what you're going to take back to your organisation, so that actually this engagement and this motivation from this week continues. It doesn't stop come Monday morning next week. This is a continuous journey, and that's what Clinical Audit for Improvement's all about. So thank you very much for joining us. The session will be recorded and made available to you alongside the slide pack. So we look forward to catching up with you all very soon. Thank you very much.
Thank you very much. Thanks for having me along.
You're welcome.